Well, good afternoon and good morning to our colleagues in the rest of the Midwest and the Western parts of the country. I am thrilled to be here as your host for today's Crisis Jam. My name is Lindsay Browning, and I am the Director of Medicaid Programming at the National Association of Medicaid Directors. Today we have a great agenda focused on the evolution of a comprehensive crisis system, and Dr. Margie Balfour will be our featured presentation. So lots to look forward to as we jump in today. But first, we want to start with some housekeeping and reminders. You all know this, but you can continue to access all of the resources from the Crisis Jam on talk.crisisnow.com. That includes the latest presentations, including last week's conversation, if you missed it, with Stacey Owens, which really focused on crisis services for service members and veterans and their families. So encourage you all to check that out. As always, we continue to look for your great ideas of who to feature on the Crisis Jam, the thought leaders across the country who are doing this work. We've had 400 unique speakers since 2020 when the Crisis Jam launched. But please send in your great ideas for additional speakers to feature. All right, we want to highlight a couple of news articles this week. The first one is coming out of The Guardian, and the headline there is a leading advisor quits over Instagram's failure to remove self-harm content. We know in both the UK and the US, there's increasing scrutiny around Instagram and Meta's response to the emerging research on self-harm and social media. And clearly the headlines are picking up on the continued focus and continued challenges around Instagram's response there. The next article I wanted to highlight is again the tragic news of Nex Benedict's death. And the headline there is around the urgency of calling for action around bullying and support for LGBTQ teens and youth mental health. Next slide. And then finally, on the headline front, ending on a lighter note, NYC Health and Hospitals has launched a new partnership with the American Foundation for Suicide Prevention, focused on supporting employee well-being and some interactive screening tools to do that. We obviously know there's been a big focus on the health and well-being of health professionals and how to support them in their work. So I think a really cool initiative that folks may want to check out. Next slide. Thank you, as always, for folks for sharing where you see 988 in the wild. One of the folks who participates in the Crisis Jam spotted this image of Melissa McCarthy, I believe on RuPaul's Drag Race, wearing a jacket that was promoting 988. So just love to see the word spreading around 988 and encourage you all to send us your 988 spotted in the wild images as well. And finally, a reminder of the Crisis Now Global Summit coming up in Amsterdam, June 29th through 30th this year. We encourage folks to join us for that. It will be a great opportunity, and there will be a poster session that will accompany it as well. So an opportunity for those of you who would like to submit information or would like to submit to be considered for that poster session, please do so. It's a great opportunity to highlight your great work at this summit. And there's information in the chat on that. All right. So let's go ahead and jump into our trivia hot seat. And I'm going to invite Jonathan Thomas to join us. He is the Chief Operating Officer at the Adam H. Board of Franklin County. Jason, are you here with us? Or Jonathan, I'm sorry, are you here with us?
I am, thank you.
Wonderful. So the question we've got today for you actually comes from the vault, meaning it was asked a while back, and we are bringing it back. So we'll see if any folks on here remember the answer from the initial time it was asked. But Jonathan, the question we have for you relates to Connection Health Solutions. So Connection Health Solutions pioneered crisis receiving no wrong door beginning in 2009. Per Dr. Margie Balfour, crisis services are fully integrated at the payer level. And here's our question. And 15% of adults present with SUD as primary. How many have an SUD diagnosis and or positive toxicology? So you've got a range of options here, kind of from 35% all the way up to 65%.
This is an excellent question, Lindsay. I know you said earlier that the people would be helping me with answering here. I'm sure Dr. Balfour would maybe upset if I don't get this right, given the amazing data that I know she's been a part of producing around the country. When do you want me to give my best attempt? Right now or after the?
Let's see what the audience says, and then you can decide if you want to take their advice or ignore it.
A lot of smart people on this call.
So folks can fill out that poll. We'll show the, oh, you've got some split results here.
Those are very split results. How many have an SUD diagnosis and or positive toxicology? Can I ask a clarifying question?
I think so, but I won't be the one to answer it.
I see Dr. Balfour's on there. If we're asking what percentage of the people with a SUD primary diagnosis also have the positive toxicology.
Total people coming through the crisis center.
We're challenging the 15%. In challenging the 15%, I would select C, 55%.
All right, what's the answer here? Can we show the results? It's actually 65. So just a little more context. So methamphetamine and alcohol account for 75% of SUD diagnoses, and crisis receiving services benefit from medically monitored detox capabilities, MAT initiation, and SUD counseling and peer support. So a little bit higher than what you guessed there.
Wow.
Yeah, and it's probably an underestimate because there's not a really good, reliable point of care test for fentanyl. And you can't test for any of the synthetic cannabinoids, which we know people are taking. So it's probably more than that.
Well, Jonathan, we appreciate you giving it your best guess, and yeah, a little tough with the audience split results today. Not as helpful as sometimes it is.
No, it was fun to be here. Thank you very much.
Yeah, thanks for being in the hot seat. All right. So with that, I think it's the perfect transition to our feature presentation today. And Margie, as you jump in, feel free to reflect on the trivia hot seat question as well. But really thrilled to have Dr. Balfour here with us today, who's the Chief of Quality and Clinical Innovation at Connections Health Solutions and Associate Professor of Psychiatry at the University of Arizona. She's going to be joined in this presentation by Sergeant Jason Winsky, who's at the Tucson Police Department. And then we'll do our roundtable and invite Jason and Johnny Gasper to jump in at that point as well again. So with that, Dr. Balfour, I'll turn it over to you.
Yeah, and thanks so much for having us. And I'm glad you did that trivia question because it reminds me, because we do everything integrated. And I sometimes forget to talk about substance use because in my mind, we do it all together. But yeah, we expect that every patient could have a co-occurring needs. And so that's woven into all that we do. But thanks for having us. And I think the impetus for the invite was we recently had SAMHSA came out to Arizona and went to multiple places around Arizona. And when we went down to Tucson and some of the folks from the Crisis Jam were there, hear us talking about some of the work we do, but hadn't heard really the whole story put together of how we got here. And next slide. And many people have seen either this graphic or versions of it, earlier versions of it. What people may not know is that this is based on, it's not just made up numbers, it's based on data from the Southern Arizona crisis system. So, I made all the pretty graphics, and Johnny, who is one of our roundtable speakers, is the one who's collected all this data, and it's for the whole Southern Arizona region. But just sort of an overview of the crisis system down in Southern Arizona is we've got our services aligned on a continuum of least restrictive, which is also least costly. So you've got our crisis line, which now 988 points to, that gets about 6,000 calls a month in Pima County. They resolve 80% of those on the phone, just like we're expecting now for our 988 across the country, via telephonic counseling, but also because we're an integrated system. That and some of the stuff you'll hear that Johnny talked about, they're able to make appointments for people, and that can help resolve the crisis too. We've got over a dozen mobile crisis teams, clinician-only mobile crisis teams that go out and respond typically within a little over half an hour. And they resolve most of those crises on the phone. It's either two clinicians or clinician and a peer typically. Then we've got our crisis facilities, which we'll hear more about. And we run the largest one in Southern Arizona down in Tucson, but there are others in the Southern region too, some smaller ones. And 60 to 70% of those people going through those are able to get their crisis resolved in that 24-hour period and be discharged back to community-based care. Then there's some various post-crisis wraparound services to help people get connected. There are some lower acuity crisis residential, crisis respite type places where people can step down or access them directly. Say the mobile team could arrange for them to go there. And then at every point along here, if you're familiar with that sequential intercept model, which the intercept 0 part was actually born in Pima County, it's designed to make it easy for law enforcement and the justice system to divert people into this clinical system. So there are crisis line staff that are co-located in the 911 call center, so they can intercept over 1,000 calls a month. And then they take that call right there. So there's that trust between the two different types of call takers. If they need to, then they can dispatch a mobile team, and it goes through this whole clinical route with no law enforcement. There's incentives baked into the mobile crisis contracts that incentivize them to respond to help law enforcement in the field. And then, as you'll see, the crisis centers are all set up to make it faster and easier for law enforcement to drop people off rather than to take people to jail. So all of these decisions on how this is organized together contributes to these overarching goals of decreasing jail and emergency room and hospital use. Next slide. And for those of you who've seen me present, I often end with this slide that kind of gives, and I just updated it recently, but it kind of gives this to talk about how we didn't get this amazing crisis system that we know we're blessed to have. It didn't happen overnight. It was a journey over 20 years. And so I'm gonna hand it over to Jason. Well, in a minute, I'll hand it over to Jason, but we wanted to go through the story of how we got here. Because a lot of communities are, in their more earlier stages of having a crisis system. So I want to back up though. Next slide. So we can back up to in the 1980s. So we're all wearing parachute pants, and MTV actually plays music videos. And to talk about some things that happened at the state level that kind of set the stage for this. So in the 80s, there was a lawsuit called Arnold versus Sarn that was done on behalf of people with serious mental illness. And then the state was under like a 30-year oversight court settlement for this. And part of what came out of that was that Arizona had to buy into Medicaid, which they were the last state to do that. And that was in the 80s. And then there was a bunch of work that happened to kind of get it to this point. But what has evolved is this structure where you've got at the state level, it's our Medicaid office that braids funding from multiple sources. And then they divide the state into 3 regions: the north, the central, which is Phoenix, and the south, which is where Tucson is. And they contract with a regional behavioral health authority who is then responsible for organizing and oversight of the crisis system. And then they contract with crisis providers like us. So I sometimes call them our benevolent overlords, because they are more than just an insurance company. They do a lot of work, which you'll hear about, to organize all of this and coordinate all of what we do. And so if you've ever looked at the roadmap to the ideal crisis system, that's one of the reasons we talk about that accountable entity so much, because it's so important. Also, something to note is if you look at Arizona, over 70% of Arizona lives in either Metro Phoenix or Metro Tucson. And so if you look at the rest of the state, that means it gets really rural really quick. So I'm gonna be mostly talking about what happens in Tucson, but Johnny is responsible for overseeing some really rural places as well. So next slide. So I hand it back over to Jason to talk about some of the things that led up to the crisis center being built.
Hello, everybody. I'm Jason Winsky. I'm a sergeant with the Tucson Police Department. I've been there 20 years and I supervise our mental health team. And like Dr. Balfour said, I think looking at the system that we have now, it's important to look at how we got here, right? And, you know, one of the things that we have to really look at is almost 20 years ago now, right? We had a very tragic but kind of sentinel event happen here in Tucson, where a Pima County Sheriff's deputy actually interacted with an individual in crisis and was trying to get that person help with very limited resources at the time. This was about 2005 here in Tucson. And the deputy ended up interacting with that same person more than once in the day. And the second time was actually just outside of our county hospital here. And again, this is almost 20 years ago now. And the deputy ended up getting into a scuffle with the person in crisis, and a good Samaritan, an elderly gentleman driving by, tried to help the deputy. And all three of those individuals ended up out into traffic on a major road in Tucson in front of our county hospital. And unfortunately, they were hit by a car, and all three of them, the deputy, the patient, and the good Samaritan, were unfortunately killed in that incident. And that's a very tragic story, but I tell it because born out of that tragedy, right? Our community here really came together, and it's been that model here ever since, to say we have to do something better for people experiencing crisis in our community. A big committee was formed by our county here, and a very unique thing happened, especially for 20 years ago. Law enforcement got to be a part of that. And one thing that came out of that committee was a bond that was overwhelmingly passed by the voters, especially considering today's standards of politics. And the bond ended up building a big campus where our crisis center now that people are so familiar with is located. And law enforcement got to be in on the ground floor of that design. And that really is unique even today, 20 years later, because you still don't see law enforcement sometimes participating in the standing up, right, of some of these systems. And sometimes that's our fault as law enforcement. But even with all that collaboration, several years later in 2011, when our crisis center opened, it did experience quite a few, you know, twists and turns, let's say, as it opened. And it took several years to really get it right. And that's where Dr. Balfour and her team kind of enters the story here in Tucson. I think it was 2013, 2013, 2014, when Connections came to Tucson and took over our crisis center here. And that's really the model that you see today that's gained all this nationwide attention. And for more on that, I'll turn it back over to Margie.
Thanks. And you can go ahead and go to the next slide. Yeah, so the Crisis Response Center, like Jason said, the bond was passed in 2006. It opened in 2011. We came along in almost exactly 10 years ago in 2014. And because Connections had been founded up in Phoenix in the mid 2000s, and one of our co-founders was the CMO and then the CEO of the REBA up there, and then kind of really pioneered that high acuity observation model. So we were asked to come take it over. And I was in Texas minding my own business, knew nothing about Arizona, and then moved to Tucson to do this. And it was really built to be the crisis center, the no wrong door law enforcement drop off for the community. We currently serve around 12,000 adults and 2,400 kids per year. Both adults and youth services have a 24/7 walk-in urgent care. And then both of them have in separate a 23-hour observation unit. And this unit is for people who would otherwise be boarding an emergency room. So they meet criteria for inpatient care, danger to self, danger to others, psychotic, agitated, intoxicated, et cetera. But our philosophy is that a lot of those folks don't necessarily need to go to the hospital. If you start treatment early and aggressively, meaning like our door to doctor time is one of our most important metrics to get treatment started. We've got our social workers on the phones with families and friends and clinics trying to figure out what's going on with that person. If people need detox, we're doing that too. We have peer supports that are doing groups and one-on-one interactions with folks. And we don't assume they're going to the hospital. We try to do all that we're going to do to resolve the crisis. Then we reassess them at some point in that 23-hour period. And then many have improved, and then we're able to get them into either back home or get them into substance use treatment or group homes or whatever it is that they need. And then for the adults that need to stay a little bit longer, that they can stay in our subacute inpatient unit for a few more days. And then we also can admit to all the hospitals all around town. The bond also built right next to us, because it's basically on the county of the campus of that county hospital. So it's actually two bonds together. And the other bond built a 66-bed inpatient psych hospital that's run by the University of Arizona and now Banner University Medical Center. And that's where most of the involuntary civil commitments go. It also built out a breezeway that connects us to the emergency room of that county hospital. So if people have medical issues, we can easily transfer them back and forth. There's also a court there, like a full service courtroom there, that the civil commitments happen in, but they do some other court stuff in there too. Next slide. And it really was, like we kind of mentioned before and on the video earlier, people talk about CIT a lot, and people often conflate that with just the training, which the training is at the centerpiece, but the founders of CIT will be very quick to remind people that it's not just training, it's a whole community response. And so that means that the police need, if they're going to train them to divert people to treatment, then it's divert to what? They got to be able to be taken somewhere. And so CIT is actually laid out what those criteria for a receiving center ought to be. And I highlighted the two in the middle because when we took over and when we, go around the country, we see that these are the hardest to do well, which was no clinical barriers to care, meaning anyone can come. You take everybody. We actually want the high acuity people that often, like in behavioral health, has this reputation of being difficult to access, right? Like there's all these exclusionary criteria. If you can't be too agitated, you can't be too violent, you can't be too intoxicated, your blood alcohol level has to be a certain way. A lot of places are wanting to do voluntary and not the involuntary population, which I'll talk about later in the data corner. But we want, our philosophy is you want those are the people most in need of specialized care. And if you say, well, I have to go to the ED, they're not going to get good care in an ED. They need to be somewhere where they're going to get specialized care. And so we want those folks. We don't use security though. We train our staff up. And then it doesn't make any sense to default to somebody with less behavioral health training than our staff. So that's how we do things without using security. Next slide. And this shows how the law enforcement was at the table, and part of what they really wanted was a secure entrance. So we have a secure gated sally port. And so they can drop people off. They don't have to take their guns off. They don't have to walk through the front lobby where it's all awkward. They can get their work done there. And then you can see our data shows, these are law enforcement drop-offs, many of which are voluntary as well as the involuntary, and also our youth. And then the circles are the turnaround time in minutes. So we're getting them out in 5 minutes typically. Next slide. And then, we measure a lot of outcome measures. And I'm not going to go through all of these, but I'll put some, part of what our charge to do was to also advance the field and start to document what we do in crisis services. So we've created a set of outcome measures that many of them are also used at the REBA and the state level, which Johnny can talk about. Next slide. And then just to end my portion here is that we really, as crisis evolves, the crisis field evolves, we really need to distinguish between the different types of facilities, because I mentioned a lot about the ability to take high acuity people. And so we're over there kind of on this left side of the spectrum. But you get problems when there's a mismatch, when the facility is really more in that moderate area and can't take the high acuity people. You either get dangerous situations where it's not safe for the higher acuity people to come, or you get the community upset because they thought it was going to be able to take everyone, but it really can't. And so I know SAMHSA is doing some work on service definitions, and that's really important for this reason. Next slide. Now, Jason can, take over.
Yeah. So another part of this history and this story here that kind of explains how we got to where we are today, looking at the system that we have now, is our police department and our sheriff's department here in Tucson. We always had, like, we were early adopters of crisis intervention training. I think we're celebrating 21 or 22 years now of that training, actually. And so we had this foundation of kind of culture and training at both our sheriff's department and our police department. Next slide. And then as a result of yet another unfortunate critical incident, we decided first at the sheriff's department and then at my department, the police department, to stand up dedicated mental health teams. But really the stars aligned again because we had this foundation of culture, and then we had a well-functioning crisis center, right, that really had come online right around that same time. And then we had a change agent chief that came in, right, from the outside to our police department here that was really interested in alternatives and diversion and deflection. So all of those things kind of happened at the exact same time for us to stand up these dedicated mental health teams, and working very closely with our regional behavioral health authority here, which is now called Arizona Complete Health. We stood up these teams, and they're really unique because, and you're seeing more of these around the country now, but in 2014, there weren't a ton of these. Our mental health teams here, we really don't do anything else other than crisis, right? And interacting with vulnerable populations. And we're at the crisis center here every day. We're constantly talking to Arizona Complete about our friendly faces and making interventions for people. And really at our core, we're a diversion and deflection unit. Next slide. And a big focus for us right now has been standing up a co-responder model. We've done one before, and we're bringing one back online again in a sustainable way during the pandemic. Unfortunately, we had to shift those resources. We're big believers in a co-responder model here. Again, working very closely with our crisis center. We're actually super lucky because our crisis center, the organization that runs that, is providing our co-responders for our co-responder 3.0 program. So it's going to be people we already know and a culture we're already familiar with. So we're very lucky with that. And then we'll be working with our REBA Arizona Complete to make sure that it's sustainable for the future. And so, I think for us, it really is, we're kind of a yes to all model here, and we're constantly trying to evolve and adopt to the future challenges. And, how to leverage co-responders is a really big topic in conversation right now. And Dr. Balfour has done some good work. So I think before we get to Johnny, we got one more slide, next slide, where Dr. Balfour is going to talk a little bit about how we're going to implement this co-responder model.
Yeah, like what's evolved over the years. We've really, like, co-responder is just one part of it. We really moved towards thinking about the whole thing as a collaborative model versus a co-responding model. So, a lot of attention is put on that orange part of the crisis, where there's an acute crisis, there's like a discrete event, it's high urgency, and someone needs to do an intervention right away. And if there's no safety risk, then that should completely be the responsibility of the mental health system, and law enforcement should have nothing to do with it. And that's SAMHSA's vision of the someone to call, someone to respond, a safe place for help. So 988 and mobile teams and crisis facilities. There is a safety issue, then the more robust and the more options you have in your crisis system, you can move beyond just a co-response to different types of collaborative responses. So sometimes the fastest thing is to identify on the phone, yeah, that person definitely needs to go to the crisis center, and dispatch a CIT trained officer to go pick them up and bring them to us. Sometimes, like, if someone's in their house and they won't come out and the police have a pickup order for the civil commitment system to bring them in, used to be calls to the SWAT teams in many communities for that. Now the police can call the mobile crisis team, and then they can go and assist them. And the community took those down from 14 a year of SWAT team call outs for this situation down to like 0 or 1 a year now. But then the blue part, because after the crisis, it's really important to make sure people get connected to what they need before things develop into another crisis again, and you've got a cycle. So there's opportunity for prevention and for outreach. And these are multiple touch, low urgency type things. So again, if there's no safety or criminal nexus to that, then the behavioral health system should be totally responsible. One thing that Johnny's team does is they have a a system of what we call second responders, people to do like peer wraparound and things like that after the crisis. But if there is a safety risk, that's where Jason's co-responder teams come in. And there's some other ones also in Pima County. So Jason's team focuses on high public safety risk people. There's another co-responder team that focuses on opiates, and they've got a peer they started off through a SAMHSA grant, but now it's permanent, that goes with them to follow up for those folks. There's another homeless outreach team that also has peers with them that does outreach out in the parks. And so you can start to organize your things. So you pick the right collaboration for the right situation. Next slide. Yeah, and that's it. So I think we're ready for our roundtable.
Wonderful. Thank you both so much for those perspectives. I think I'm going to actually turn it to Johnny first for our roundtable, and then we'll hear from Jason again. Johnny Gasper is the Director of Justice and Crisis Systems at Arizona Complete Health. Johnny, would just love to hear your reflections on the presentation, the approach that Margie just shared.
Yeah, happy to be here. Happy to share. As Margie mentioned, I get a unique perspective with those braided dollars for being the contractor for our crisis services within 12 counties in Arizona for the first 24 to 72 hours of crisis services, including the crisis line, mobile teams, as well as the observation unit, but also our separate hat as a health plan. So one of the most amazing things about the system is it really benefits from leveraging the clinically appropriate, which is often the least restrictive setting, is also beneficial not only to the community member, but also to us as a health plan, right? Reflecting on that, and again, reflecting on the relationship that Margie or Dr. Balfour, Margie, Jason, and I have is, we all have each other's personal numbers. We text each other, we talk all the time. And that type of partnership is what we pursue in our rural and frontier communities as well, in 11 other counties across the state of Arizona. Our team hires many retired first responders really to help bridge that gap, similar to what you're hearing today, to try and connect crisis services to our communities, to 911 communication centers, law enforcement, fire, and EMS to help generate partnerships and the trust necessary to leverage these parts of the system. I'd say this is particularly of importance in our rural communities, where we've done things like help co-locate crisis mobile teams in both PSAPs, so 911 communication centers, as well as in police departments. So that way they can get to know their responders in the community and generate that sense of trust. In addition, like Margie mentioned, we do have 911 partnerships and co-locations here in Pima County that allow us to have computer-aided dispatch access, as well as linkage into the crisis lines EHR with co-located crisis line staff. We're looking to expand that into our rural communities as well in the next year. So though Pima County has robust resources and is certainly the model, it is leverage, and again, starting with the partnerships that we see here to try and expand the opportunity to get crisis services out to our community members.
Really appreciate that point around partnerships. I think so much of this work begins at that foundation, which is both, professional and personal partnerships and relationship, as well as organizational and built into the structures of organizations, the partnership elements. So I want to go to Sergeant Jason Winsky for any additional reflections you have as well.
No, I don't think so. I think, just to kind of close my comments, I would say, we have a collaborative system here. We really do. And I think that's the foundation for the success that you see today. And it took a long time to get here. And it's a work in progress. We're far from perfect. We're constantly trying to evolve and do better.
That's great.
I know as a quality improvement nerd, just yesterday, the day before, we were talking about this some complex problem around civil commitment. And Jason said, we need one of Arizona Complete Health swim lane diagrams. So we've all turned into these collaborative nerds, quality improvement nerds, which is really great.
Absolutely.
That's awesome. I know we have a bunch of questions in the chat, probably only time to get to one of them. So the question I'll raise, and I think Margie, probably primarily for you, on that last slide, you were talking about how you use the co-response model versus other models. I think there was a question around how that intersects with some of the federal rules around kind of an expectation for a 2-person crisis team to respond and to be able to get Medicaid funding, the enhanced Medicaid funding for some of that. So I don't know if you have any insight.
I think that's more of a Johnny question. because he's the one who pays.
Yeah, so I'll take this and I'll say kind of, and this is part of the evolution of our co-response model in Arizona, right? We've kind of followed the LA model in the past. We have placed mobile teams in vehicles with law enforcement officers in the past, but right now that's again evolving as Jason mentioned, right? We're looking to partner peer-based organizations through connections and looking to fund that more so on the fee-for-service side, looking at it more as kind of an aftercare and investigative practice, and still allowing crisis mobile teams, those two-person teams, to really respond to the crisis calls that are coming in through either 911 communications or through the crisis line. So we try and be as creative as possible is probably the easiest way to describe it. But again, referencing that some of the services can be provided at one support side of our crisis continuum and some on the other.
Really appreciate that, and just want to thank all three of you for your incredible work and taking the time to share your insight with this group of 230 leaders from across the country working on crisis services. It's really helpful to hear your all's experience and how you've built the critical foundation of partnership. So I'm gonna unfortunately have to keep us moving. I know there are questions in the chat, and I think some of our presenters are responding to those. But I'm going to go ahead and transition to some of our regular updates. I would love to go first to our SAMHSA update, and I believe John Palmieri is on to give that update.
I am, yeah, thank you. It's good to be here. And really appreciative of this opportunity to learn. I'm always learning from our partners in Arizona on all the work, the tremendous work that they've done in building their crisis system. And actually and they've been like just incredibly gracious with sharing what they've learned, what's gone well, where they've struggled, what data they've collected. And it really has enriched all of the work around the country through their generosity and through their expertise. And it actually does link to one of the updates, which is that we are very near a policy academy that we're running with our Training and Technical Assistance Center, which actually will happen in Tucson at the beginning of April. And we'll have an opportunity to connect with some of the partners who are on the call today. So very excited about that, where we are bringing 10 teams, state, territory, tribal organizations focused on crisis systems design and incorporating systems engineering principles in building out more robust crisis systems. So very much looking forward to the opportunity to be there. And then I also just wanted to provide a couple of other updates. One is that also with the support of our Training and Technical Assistance Center, our 988 office recently held an equity convening at SAMHSA headquarters over the past couple of days, which involved about 70 in-person and virtual attendees, including grantees, crisis centers, community providers, leaders, and a number of other partners engaged in incredibly rich dialogue, sharing, networking, exploring approaches and examples of how they are all working to embed equity in 988 and crisis response efforts, including sharing concrete strategies, models, and tools that they are using to embed equity in service delivery, community engagement, workforce development, marketing and communication, among other areas. And so really excited that there was an opportunity for people to get together for this critical conversation, and then a lot more work that will be coming out of that convening as well, which will be keeping you all in the loop on. And then finally, I did want to share, I know we've talked a lot about how we are continually updating our partner toolkit. And so there is a new video that's been included now in the toolkit around what 988 is and how it works. And the video specifically features 988 crisis counselors talking about what 988 is, what happens when you contact 988, and the kind of work that they do. And how they support people reaching out for help via call, chat, and text. This is a video that has been shared as part of our some of our listen and learn sessions and has been well received. And I will throw it into the chat link so that people have an opportunity to take a look at it. And we are continuing to work, obviously, on building out the toolkit with additional materials and products that can be leveraged and used in all the communities around the country. And so I think that's it for me now, Lindsay. Thank you.
Wonderful. Thank you so much. All right, well, let's transition to our NASH pit updates. And this week, Dr. Kimberly Caranda is joining us to give the NASH pit update. Kimberly is the section chief of statewide services in the Office of the Commissioner at the Connecticut Department of Mental Health and Addiction Services. So really looking forward to hearing what's happening in Connecticut.
Thank you very much, Lindsay. And I just want to thank everyone for the opportunity to share some information about an access program that Connecticut DEMAS implemented about 1.5 years ago related to the mental health crisis affecting pregnant and birthing people. You can go to the next slide. Thank you. I just want to share that for context. We have a maternal mortality crisis. The United States has one of the highest rates of maternal mortality in higher income countries. And what that means is that we're losing over 1,200 birthing people every single year. If we look at these statistics, also really important to know that minority women are 2 to 3 times more likely to die of pregnancy-related causes than white women. And this is regardless of socioeconomic status. We also know that mental health and substance use disorders play a role in over 25% of the deaths. And, we're really aware of these concerning statistics because of the work of maternal mortality review committees that are really delving into pregnancy relatedness to all of these untimely deaths in our nation. I added here a link to the CDC's campaign Hear Her for those who might want to delve a bit deeper into some of the research and data. This is a campaign that really raises awareness of some of the life-threatening warning signs during and after pregnancy and ways to mitigate these issues in ways that can potentially save lives. You can go to the next slide, please. So I've titled this slide Perinatal Mental Health Impact on Pregnant and Birthing People, but the reality is that PMH also impacts the developing fetus. It impacts infants, children, and really the entire family system. So individuals who have these daily struggles around managing their physical and mental health also may begin to increase their use of alcohol, tobacco, other drugs. Their parental interaction and bonding in terms of being able to respond to their infant or children can be affected. And some of these challenges, and we see this in our programs on a daily basis, they can become so serious that it might lead to involvement of child welfare and in some cases loss of custody of their children. Obviously, the most extreme challenge can really lead to death. So in response, in order to mitigate some of these really significant concerns, Connecticut focused on ways to educate and ensure access to care for our systems that support pregnant and birthing persons. You can go to the next slide. So our program is Access Mental Health for Moms. We dedicated federal block grant dollars to the program, but I do want to clarify that the support is not only around mental health, but also substance use disorders. And this was really critical for us in Connecticut. We've been really significantly impacted by the opioid crisis. And in fact, we rank number 8 in the nation in terms of opioid overdoses. So we're contracting with our administrative services organization, Carillon. They have already been managing a similar access mental health model for children and youth in our state. They have a full-time clinician, a care coordinator that are dedicated to the program, and they are the first point of contact for callers. We also have a statewide hub team that's comprised of 4 reproductive psychiatrists, one of whom is bilingual Spanish. And Dr. Adriana Ferre, who's our hub team medical director, works at Yale. And very importantly, she is a member of Connecticut's Maternal Mortality Review Committee. The program supports a lot of different kinds of practitioners. So it's not only OBGYNs, but PCPs for adults and for children can call in, psychiatrists can call in, staff at FQHCs are also open to call in. So we have real-time phone consultation. That might mean helping a practitioner around the psychopharm recommendation, maybe clarifying a diagnosis, and also very importantly, potentially managing an opioid use disorder during pregnancy. We also have staff that are able to really identify and help to connect and facilitate connections with community resources. Next slide. So I just have a snapshot from our website. You can see that we're currently operational from 9 a.m. to 5 p.m. Monday through Friday. There's our number, and we've been really tracking. We'll continue to track on the calls that are incoming to our number, but we did find that the hours of 9 to 5 are really the times that we get the majority of the number of calls into our access line. You can go to the next slide. I wanted to highlight our provider training resources. We're continuing to develop our website, and we add resources every day, both for pregnant and birthing people, but as well for our provider system. So we have a developed toolkit. It's very robust with addendi and various screening tools. Some of the things that I've highlighted, we've gotten a lot of feedback from our provider system that they've been very helpful, but we've also incorporated some other resources from a grant that we have through SAMHSA. It's our Parents Recovering from Opioid Use Disorders, our proud SAMHSA PPW pilot grant. And in that grant, we have dedicated funds to the Connecticut Hospital Association to work in coordination with us around maternal mental health related topics and webinars. So those are also incorporated on our website with links and open to everyone. They're all forward facing. You can go to our next slide. Just to wrap up, I've just included some contact information here. Please don't hesitate to reach out to me directly, to the Director of Women's Services at the department. And I've also included a link to our Women and Children's Services at DEMIS, as well as the actual link to Access Mental Health for Moms. Thanks again.
Wonderful. Really appreciate hearing about that work. I know mental health for pregnant and birthing people is certainly a top concern. I hear a lot in the Medicaid world, and really incredible to hear kind of the solution you guys are putting in place to try to wrap around other providers and help them feel positioned to support clinicians in delivering that care. So we're going to go ahead and shift gears to our data corner this week, and I'm going to invite Dr. Margie Balfour back to join us for that, and then we'll hear from Matthew Goldman. So Margie?
Yep, I'm back. And next slide. And just real briefly to tell you about a research study that just came out. So as we talked about before, like a lot of studies talk about an individual program and the impact on an individual program, but we have this really great and comprehensive, and it's been around for a long time, comprehensive system. So we wanted to look at how people flow through the system and how that impacts other service use. And so we worked with our partners at Arizona State University, and they have a database of all the Medicaid claims and constructed these care episodes. And so what this graphic on the left shows is how people flow, like where does their crisis episode start and where does it end? And so what we found just from doing that is that most crises, so 57.4, began with either a mobile crisis or crisis facility rather than the emergency department. And we didn't include the phone. So this was all started with mobile crisis or crisis facilities. Then of those people, most 69% remained in the crisis system. So they either ended in mobile crisis or crisis facility. So this shows if you have a comprehensive crisis system, people will use it, and that can help impact and lessen the utilization of emergency rooms and inpatients. Then we wanted to see, well, what happens after the crisis? And so for the people that went through the CRC, we had electronic health record data for that subset. So we started with like 40,000 episodes, and then there was about 9,200 that came through the CRC, and we merged that with our electronic health record data. And then first we looked to see, did they utilize any more crisis services in that 30 days? Most didn't, so 63% didn't. Of those that did, over 70% of that utilization was another crisis service, which we thought was good. That shows that they used it before and they'll use it again. Next slide. And then we look to see what factors either predict, or either associated with utilization or associated with less utilization. And a couple of the interesting findings, as you would expect with social determinant type what we know about that is that, we saw people who are Black race, homelessness, have more utilization. Stimulant use and psychosis was another predictor of utilization, which in our settings primarily meth. And then interestingly, the involuntary population. So a lot of crisis centers, don't want to take involuntary people. And we feel very strongly that those are the people most in need of specialized care and that we should take them. So when we get involuntary patients, we really work to try to engage with them and convert them to voluntary status. And so about 60% of who went through the CRC who started off involuntary, we converted to voluntary status. And then that group, as well as the group that stayed involuntary, had less likelihood of reutilization. So that says to us that having these involuntary services, if you were to exclude them, they wouldn't have had that opportunity to be converted to voluntary, be engaged in that less restrictive care. And and this shows that they have pretty good outcomes. Next slide, and that's the end of mine.
Thank you, Margie. Really appreciate your sharing those findings. It was a pleasure working on that study with you and the Arizona team. And what I just wanted to highlight from that is those methods that Margie was describing, we've developed those in a lot of different settings. I have here on the slide a link to a methods paper that describes implementation evaluation that we did or are still conducting in San Francisco that uses similar methods. But I just want to emphasize, so much of what I've been sort of ringing the bell on in Data Corner is a need for expanding the evidence base for crisis services. And the types of methods that Margie just described of looking at a whole system, being able to combine data sets in order to make these really helpful and informative claims is something that ideally we'll be able to generalize by replicating studies like that in multiple different settings. So I've been pleased to already hear that there are some other systems that are interested in conducting a similar analysis, and we certainly hope to see that kind of research repeated in other environments as well. On that note, I'm putting out a call for all data people. If you or someone you know wants to present at a future Data Corner, and this could be all things data, so research, evaluation, quality, dashboards, anything that would seem to fit in this Data Corner space, I would welcome you to please email me, and you can have a few minutes at the 988 Crisis Jam to share your work and disseminate your findings. So please do be in touch. Thanks so much.
Wonderful. Thank you both so much. I'm going to shift to our federal updates. So we're going to hear from Joanna first from AFSP and then Sarah at GCS.
Hi, everyone. Yes, we were hoping for more of a finalized update for you all today regarding the FY24 budget deal. But what we are hearing is there will be a finalized bill shortly. We heard it should be released today. So hopefully by the next time we're updating you, we'll be able to give you numbers for FY24 as we head into FY25, which I know Sarah is going to sort of go through a little bit in terms of what we can expect from the president's budget, which was released. But we are hoping to have a finalized FY24 deal shortly. So exciting to hear that coming down the line. Sarah, I'll pass it over to you.
Thank you, Joanna. And if we go to the next slide, just a few highlights from the president's budget request document that was released last Monday. This kicks off the FY25 appropriations process on the Hill. And while it is not binding, meaning that these numbers have to happen on the Hill, it shows what the priorities are of the administration. So just some quick highlights. SAMHSA overall strong, continued robust funding request as part of this document, $8.1 billion overall, which is a $612 million increase above FY23. The Lifeline request is $100 million over the FY23 levels, which is the last amount, as Joanna was saying, that we have finalized as of now. FY24, we don't have those numbers yet. So it's based off of increases over FY23. For the block grant, for the mental health services block grant, it looks like it's requesting $1 billion, as well as the 10% crisis care set aside up from 5%, and a new 10% early intervention prevention set aside. Also within the request is $40 million for the Mental Health Crisis Response Partnership Program, which is a $20 million increase over the FY23 levels. Continued investment request in CCBHCs, $450 million is included in the document, which is a $65 million increase, as well as a new line item continuing some COVID emergency funding that was available previously, and they're now proposing a new line item for community mental health centers at $413 million, as well as one more new item just to flag, among many other items, of course, is $1.75 million for older adult suicide prevention grant program, and that would be another new request within that document. So I encourage you to take a look at the budget request and prepare ourselves for a new fiscal year as we're wrapping up the old one. Thank you.
Thank you both. All right, I'm going to pass it to Stephanie Hepburn for this week's crisis talk. Stephanie?
Thanks, Lindsay. Thank you. So I'm going to bring on Dr. Scott Zeller. He's the former chief of psychiatric emergency services at Alameda Health System in Alameda County, California. Dr. Zeller, you've been long troubled by disparities in emergency medicine. Can you share what those are and how you've developed empath, crisis stabilization units, in response?
Yeah, hi, and thank you for having me on. Really, I would continually see stories about psychiatric patients boarding in ERs across the USA. And as Margie and others were saying earlier, ERs aren't a great place for folks to be, but they are getting stuck for long hours, sometimes days in those ERs, waiting for inpatient hospitalization, which was thought like the only possible destination. And they were usually untreated during that time. So what we knew from emergency psychiatry is that if we could get folks out of the ER, maybe right next door to a much more comfortable, soothing unit, have them have immediate access to a psychiatrist, that we could actually get them started under treatment and end up 75% or higher of those folks end up needing no hospitalization inpatient. We also reduce the number of people needing physical restraints from usually 15 or 20% in an ER to far less than 1%, usually 1 or 2 out of every 1,000 patients in an empath unit. So empath stands for Emergency Psychiatric Assessment, Treatment, and Healing Unit. They're working hand in hand with ERs within that hospital. And it's really for this population that would historically be stuck in the ER. And instead, we're moving them quickly. If somebody has a psychiatric emergency, the federal law considers that a medical emergency, and yet it's the only one historically that's been treated by find them a bed. If we can actually treat them just like we would every other medical emergency and quickly move people out, just like if they came to the ER with being pregnant, we'd quickly move them to labor and delivery. We can quickly move them to an empath unit where they're with the right personnel, the right environment, and we get some really wonderful outcomes with the great majority of folks getting better and going home or some less restrictive alternative in less than 23 hours.
Dr. Zeller, if you could just quickly touch on what population is the best fit for empath, and also tell me a little bit about the home-like atmosphere. What makes it very different than the ER?
So it's really intended for that high acuity population that often ends up in emergency departments, and they maybe have comorbid medical things, like somebody who took an overdose, for example, in a suicide attempt. They probably shouldn't be going to somewhere just for psychiatric intervention, but you need medical attention as well. So a lot of those folks are going to go to the ER, even in places with wonderful crisis systems. So empath is a part of the crisis system. It's not intended to replace anything. It's just specifically to be in that role for that high acuity hospital population that ironically has been the highest acuity in any region, but at the same time, the most underserved. So we want to get those folks seen just like we would anybody else in these systems. And when we're doing this, we can really, help these folks just as we could anywhere else. The soothing population is very similar to what we see in a lot of crisis settings where there's room to move about, needs are met. Nobody needs to ask a nurse or staff for anything, but staff are intermingled. They're not behind a fishbowl. There's ability to get yourself something to eat or drink, and really focusing on, staying into a system in a room where you're free to move about. Nobody's going to say, hey, get back there, I'm calling security. Instead, if you need to pace, that's okay. If you want a room for stretching, a lot of the empath units have outdoor healing gardens, and there's now several dozen empath units in the USA. By 2026, I think we're going to have over 100. Several states have had huge grant programs specifically to allow hospitals and fund hospitals to build empath units, and it's been amazing, the growth in these units, when the first one was only in 2016.
Thank you so much for hopping on with me. I'll pass it back to you, Lindsay.
Wonderful.
Thank you.
Thank you both. As we wrap up today's call, just a reminder of what's coming up for the Crisis Jam. Join us next week as we learn about how to add mediation to the crisis response toolkit. And then the following week, we will discuss the zero suicide effort and both implementation and outcomes of that in health systems. So thank you all, as always, for joining us today, and look forward to seeing you here same time, same place next week.